start off by talking about resources in case you need support around fertility. We have medical questions around fertility. Both Dr. Cedars and Dr. Westphal are going to talk for a few minutes about resources, and tomorrow those resources will be posted on the website, sciencecafesf.com. So without further ado, Dr. Cedars and Dr. Westphal again.
I think the most important thing, if someone is having problems, the best thing is to go in for an evaluation and talk to someone. But if you're kind of in this stage where you're thinking about getting pregnant or just want general information, there's some good organizations and I think some pretty good websites. One of the pharmaceutical companies has a website called Fertility Lifelines that I think is pretty general and has just answers to very, very basic questions. The American Fertility Association has information and booklets, and a lot of these, I think they also do like some chat, like have some of these chats, and sometimes we'll link people up to different meetings and things. And then an organization that a lot of my cancer patients uses Fertile Hope. So if you have friends who are diagnosed with cancer and are interested in fertility preservation or things that are related to cancer issues, fertilehope.org is an excellent resource for that.
Just a couple of other resources. There's a fertility support group called Resolve, and they have a chapter in San Francisco. Their website is just resolve.org, which is, I think, their national website. But locally, they have an office down in San Francisco, and I know a lot of the smaller communities around the city, and they sponsor chats with physicians. They have lots of sort of coffee clutch patients get together. They have lots of information seminars. They have information about fertility. They have information about adoption. They have information about single parenting, so sort of the whole gamut. So that's a great resource. The American Society of Reproductive Medicine, which is our parent organization at asrm.org, has a lot of resources, and actually I'm on the practice committee, and we're starting to work very closely with the patient education committee to get more information out to patients that's evidence-based and is helpful. So I think you're going to see more and more that you can access on the web from ASRM. And then for programs that do fertility, or particularly for IVF, sort of the sub-society of ASRM is SART, or the Society of Assisted Reproductive Technology. And that would be a good way to just sort of find a clinic, and it's just SART, SART.org. But for just general information, I think Resolve or ASRM are good places to start.
So I have one quick follow-up question. Just like Dr. Westphal answered, if you have the inkling that you might have a fertility problem or you're struggling with fertility, what would be your first step?
Well, I think the first step would be to go to your gynecologist and to sort of go through your history, because most patients don't need to see a reproductive endocrinologist or a fertility specialist. I think most patients have relatively simple things, and that can be handled by your gynecologist. We talked briefly about when to go. So, you know, there are certain things that the 12 months, the 1 year of infertility is really 12 ovulatory exposed cycles. So if your cycles are irregular, there's no reason to wait at all. You should go right away. If your cycles are regular, and you know that you're having intercourse around the middle of the month, if your husband lives in New York and you live in San Francisco and you see each other once a month and it's always at the wrong time, then clearly there's a problem. But it might not need a doctor to fix that problem. And so if you're under 35, 12 months, which is really 12 ovulatory cycles. And if you're over 35, then after 6 months. And again, I think a lot of people think, oh my God, if I go to the doctor, they're going to do something. And probably what they're going to do is an evaluation, but the evaluation might be everything's normal, try a little more, or we found X, Y, or Z, and then this would be sort of the treatment progression. So I'd start with your gynecologist, and either if you feel like you're not getting your questions answered, or you might get to a point at which your gynecologist feels like they've gotten to sort of the end of their bag of tricks, then they might refer you to a reproductive endocrinologist.
We're going to open it up to questions again, and I'm going to start off actually. Yeah, seriously.
With the mic.
I'm going to ask a question about alternative treatments. There's a lot of herbal treatments, acupuncture. Can either of you talk briefly about if there's been any scientific studies on herbal treatments?
That was a little bit of a setup, I think. We published a paper earlier this year where we were looking at a nutritional supplement. And we actually found that using the supplement, the pregnancy rates were higher than in the group that didn't use it. So I think in some situations, and I think the patients that it really helped were the patients who did not have regular cycles. So this nutritional supplement, we found that it normalized cycles, and I think those are the patients that benefited the most. So the supplement, I think the primary thing that helped with ovulation is chasteberry, and there's studies showing that in some women it may improve ovulation. Before I did this study, I was not much of a believer in some of these nutritional supplements. But I think for, if you're young and have irregular cycles and want to try something low tech for a short period of time, I think sometimes trying some reserval things may be beneficial.
It was called chasteberry? What was that?
Chasteberry, yes.
It's also sometimes called Vitex. V-I-T-E-X. It's the same thing.
Does being on the pill long term have any sort of implications to when you can, or how you can get pregnant, whether you're in your mid-30s or your early 20s? Being on the pill long term.
A lot of people think that when you're on the birth control pill, you're not making eggs, and that maybe you're saving this sort of decline in eggs. But the reality is when you're on the pill, you're not ovulating, so an egg doesn't get to maturity. But that process of eggs leaving the resting pool and starting to develop is ongoing. Because if you remember, it happened before you even were born, it happened before you went through puberty, it happens when you're pregnant, it happens when you're on the pill. So as best we can tell, and there's been a little bit of conflicting data, but as best we can tell, being on the pill doesn't lengthen the time to menopause, which would be the thing we would expect it would do, but neither does it shorten the time. So it has neither a positive nor a negative effect. The other thing is, the common wisdom used to be that if you were on the pill and you wanted to get pregnant, you had to be off for 3 months, kind of clear it out of your system or whatever, but you really don't. I mean, you really can take the pill until you're ready to get pregnant and stop and start trying right away. And there's no negative effect on the pregnancy or on the baby if you do that.
Yes, I have another question. Okay, so when you mentioned the previous comment about some myths around scheduling and so on, that rang true in a relationship. And I wanted to know, just for the education of my wife perhaps, there's this whole ritual about positions during intercourse or after intercourse, which at least they're very unromantic and sometimes even just sexy. So I just want to know how effective those are in terms of getting pregnant.
I told them to have sex a lot, so you can tell them about positions.
Well, obviously there are people that get pregnant no matter what position they're using.
Back of the car.
Right. So I can't say that, that there are positions where you can't get pregnant. But in general, I think most people recommend, if you're really trying to get pregnant, I mean, what a lot of people will do is, after intercourse, sometimes put a pillow under their hips and just...
You were feeding into these fantasies.
And, you not just jump out of bed immediately right after intercourse. So, it may help, to give the sperm a little bit more of a chance if you, stay and don't jump out of bed immediately. I don't know if you want to add to that.
Well, I mean, I think what you don't realize is actually the first sperm after intercourse gets to the fallopian tube within 1 to 5 minutes. So the good guys swim out pretty fast. And when you stand up, most of what runs out is the seminal secretions and not the sperm. And so while I probably wouldn't jump up the minute after, because that's not very romantic either, I don't feel like you need to put yourself in any certain position for any period of time. I mean, I tend to think that, again, you don't want the part of your relationship that's very special to become a chore. You want it to remain a part of your relationship that's very special. And so the more proscripted you try to make it, the less that is. And I think being infertile or trying to get pregnant is difficult enough for patients without sort of adding things that we really don't know are going to be beneficial. So I'm a little bit sort of more laissez-faire about that kind of stuff.
Just a quick announcement of questions. Just go ahead and raise your hand and the mic will slowly make its way around to you. So I will pass the mic around when you do raise your hand.
I have a question around once the decision is made to start fertility treatments, what are the options or the steps and the costs that are involved to sort of fully exhaust the possibility of conception?
So some people may want to move to another state if they have fertility problems. There are some states where it's mandated to cover fertility treatments and to cover IVF. California is not one of those states where it's required. Every employer has the option of adding fertility benefits if they want to, but most employers do not. So occasionally there's some people who are able to get their HR department, to add fertility benefits, but most of the time in big companies, that isn't too successful. But sometimes there are different plans. So if you're offered different plans at your employer, some of them, the HMOs usually will not cover IVF type things. Sometimes some of the PPOs will. So you may want to look into the benefits very closely, and sometimes they'll cover, part of lower tech procedures, and a lot of insurances may cover the testing, but it may not cover anything related to treatment, or sometimes they may cover things like inseminations, but then not cover in vitro fertilization. So it really varies. If patients don't have coverage for treatment, typically an in vitro fertilization cycle, the medical cost is around in this area probably averages $9,000 to $10,000, somewhere in that ballpark. And then medications are probably a few $1,000s on top of that. If patients are doing other treatments, if they're doing treatment with oral medication, that usually is not very expensive, and that is more likely to be covered by insurance. The injectable fertility medications, the FSH hormones that are used for IVF and are sometimes used with insemination, are less likely to be covered, and those medications are much more expensive.
Can you do IVF indefinitely, or is it prescribed that you do try a certain amount of time and then?
The number of times to do IVF, really depends on, on the situation. In general, I think most most people will probably try it 2 or 3 times and then reevaluate and decide if it makes sense. Now there's some patients who, who do keep trying, and I once saw a patient who got pregnant on her 10th IVF cycle. Most people don't continue doing it for that many times, but there's some people that won't consider other options. I mean, many patients will think about other things, will either move to adoption or egg donation, but if those are not things that a patient will consider, sometimes they'll continue doing IVF indefinitely. And there isn't a set number of times where, if you do it after that, something terrible happens. So, there isn't an absolute limit. And, in some countries, I've read of patients doing, 20-something times. So, sometimes people will do many, many cycles. Not that commonly, but.
I want to add something quick in. There's something called the Family Act of 2005 that's before Congress, mandating fertility coverage from certain insurance providers. And there's more information on the website about it. I'll post that.
The only thing I wanted to say is I think that what people hear about the most is IVF, because it's the most high-tech and it gets the most splash and it gets the most publicity. But most people actually don't need IVF. And so I think you don't sort of go into it. I mean, there are some people who are truly infertile, and without something like IVF, they won't get pregnant. The man has no sperm in the ejaculate, and you have to harvest sperm, and that sperm's not good enough to use for anything except IVF. The woman's tubes are irreparably damaged. I mean, there were certain things where that is the only option. But for the vast majority of couples, you can actually start with low-tech treatments. And I think the biggest issue is not so much do you start with low-tech or high-tech, but whatever you do, that you do it for a finite period of time. Because almost everything that we do, whether it's low-tech or high-tech, most of the pregnancies are in the first 3 to 4 cycles. So it doesn't mean that nobody's going to get pregnant in the 5th or 6th cycle, and if you're under 30, you might do things in 6-month blocks. And certainly if you're over 35, you're going to do things in 3 to 4 month blocks. So you don't want to get on a treadmill where you're doing the same thing over and over and over again, but you also don't want to skip simple things that while their success rate per cycle is lower, they're so much less invasive in terms of time and procedural costs and emotional costs and everything else, that you want to start with simple things, but you want to do them for sort of finite periods of time.
So for my question, I have to relate a little bit of my personal history, and I have a couple questions that go along with it. A little over 3 years ago, I was diagnosed with lymphoma, and the treatments that I had to go through. Sorry. My ovaries inoperable. So I always thought that I would have to go through IVF to get pregnant. And recently, my husband found a doctor who performed an ovarian transplant on myself, which I know is not very common, and it's not going to be something that a lot of women can do. But my questions are, do you think that more fertility specialists will be looking into this kind of treatment for cancer patients? Because it not only affects their ability to have children, but also takes them out of menopause. And my second question was, I forgot. Can you answer my first question first?
There are a lot of people that are doing research on freezing ovarian tissue and retransplanting it. Obviously, there's still a lot more research that needs to be done, and there have not been many successful pregnancies doing that at this point. But I think that definitely is one of the things that people are looking at, and I think there probably will be more and more people doing it. But there isn't a huge population, so I don't think it's going to be, it's probably going to be in a few isolated centers where people are going to have enough expertise to do that type of thing.
Part of my question is that since my sister and I were not identical twins, we're the first case of non-identical twins that had the ovarian transplant done. And because the benefits of having the ovarian transplant were also not only that we could get pregnant, but that I came out of menopause, do you think that those benefits will help kind of push the research towards doing stuff like that for women who are put into early menopause, not only from cancer, but from other ovarian dysfunction?
I think that there's several concerns about ovarian transplant. One is the non-identical donor and finding ovarian donors, which is not so easy. Two is some of the immunosuppressive agents if you're using a non-identical donor, and whether the cost, risk, benefit of having to take immunosuppressive agents versus the benefit of the ovarian transplant. It's a little bit more clear with a heart transplant or a kidney transplant, which is not to minimize the importance of having your child, but if it's an ovarian transplant, it's not your genetic child anyway. And so egg donor might be a safer, easier way to do that. In terms of taking you out of menopause, you're probably right. When we replace hormones for women who are menopausal, we replace primarily estrogen. And we think that's the primary hormonal deficiency, and potentially progesterone. And the ovary probably makes other things. But I think my sense is that while there may be some ongoing investigation, there's probably going to be more investigation in terms of ways of preserving the woman's own ovarian tissue, in terms of the ovarian tissue cryopreservation that Dr. Westphal talked about. And one of the things in Fertile Hope is really good about this, that we're really pushing for, is that before women get chemotherapy, that they at least have the option to discuss fertility preservation, because I think what happens a lot of times is we see women after they've already had the chemo, and a lot of times they're really frustrated because they didn't know that there were options that they could have done. So I guess rather than trying to find a way that has not insignificant risks to fix the problem, I would rather sort of look on the front end and see if we could do a better job of preventing the problem potentially.
That was my second question, was it was never, like my oncologist was great, and actually probably, Dr. Westphal probably knows her, she teaches at Dr. Martin, but she didn't know about freezing eggs at the time, and since I didn't have a partner at the time, like having a frozen embryo wasn't an option. So my other question was, what are we doing to inform oncologists that are going to have young women as patients that this is something that they need to discuss with their patients, because not only do you need to worry about saving your life from the cancer, but what about after that?
In the past, oncologists didn't think too much about fertility issues, and that was a pretty low concern. They were very focused on treating the cancer and, helping the patient have a healthy life. But fertility was very low on things that they thought about. And most patients that have cancer do tend to be older, and so it's a smaller subset of patients who even have the potential to think about fertility. But because of this issue, you probably are aware of Fertile Hope? Yeah. So the woman who started Fertile Hope, Lindsay Knorr, was diagnosed with cancer in her early 20s. And she was very frustrated because no one really discussed fertility with her. And so after she had gone through her treatment, she started this organization to try to increase awareness. And Fertile Hope has done an amazing job of getting the oncology community more concerned about discussing fertility. And she and her organization go to the major oncology meetings. They put on a lot of seminars. The American Society for Clinical Oncology issued guidelines a year ago about how these things should be discussed with patients. And I know at Stanford they're working on, for patients, discussing their treatment and care after they've been cured or treated for their cancer. So one of the issues is making sure that all patients are aware of fertility, and so it is becoming more common for oncologists to think about it. But there still is more that needs to be done. But I think Fertile Hope has actually done quite a bit in increasing the awareness in the oncology community.
I think it's sort of a testament to the oncologists that patients are surviving so long that it becomes an issue. I think that there was a very long period of time where survival really was the end, the goal, and living and life. And I think now that both men and women are surviving longer, I think there is a sense of thinking about quality of life, not just life, but quality of life. And I think I agree with you that it's really more than just fertility, because I see patients, and you're seeing now chemotherapeutic agents used for non-cancer treatments, like non-cancer diagnoses, like lupus, for instance. And we haven't yet gotten to those people yet. And I see patients who are coming in their 20s with hot flashes and really miserable and didn't even know that this was going to happen. And so it's really an educational process, and it's not going to happen overnight. But I feel really strongly we need to hit it on the front end, not trying to fix mistakes we made on the back end.
I just have a quick question. What are your thoughts on acupuncture along with assisted reproductive technologies?
There's not a lot of great data on acupuncture. There have been a couple of studies that have come out. We work very closely with the Osher Integrative Medicine Center at UCSF. And actually had a proposal for a study, a randomized study, looking at acupuncture versus not acupuncture, which unfortunately didn't get funded. But it's something we're very interested in. We don't tell patients not to do it because they don't think it's harmful, but neither do I tell patients that they should do it, because I think the data is a little soft in terms of telling them that it's definitely helpful. We are a little bit concerned, very frequently herbs and acupuncture go together. We're a little bit more concerned about herbs when patients are actively under management, because some of the herbal products do have hormonal effect and they may interfere with the hormones we give, as well as the fact that some of the hormonal products are blood thinners. And we've had a patient who had a serious complication with bleeding after an egg retrieval, and the only thing we could attribute it to was the herbal that she was on. So we're pretty strict about restricting herbal products when patients go through assisted reproductive technology. But my bias is the data is not strong enough to tell patients to do it, but neither do I tell patients not to do it.
Yeah, we had tried to do a study a couple of years ago too, and found it difficult. The studies that have been done, I think, are not very clear cut. I do have, I don't know, probably, I bet at least a third of my patients do acupuncture, and I think a lot of them tell me that they feel more relaxed and, you know, get some benefit from that. So I don't know if it has that much of an impact on fertility, but I think if they feel better and feel more relaxed. And a lot of patients will do acupuncture right before we do the embryo transfer. And for some of them, I think they are able to relax more, and that in itself is helpful.
So I have a comment first, and that is that when a couple gets pregnant, the woman and usually the couple is going to be asked to come in by their HMO for a class where they talk to them about, you know, foods to avoid and so on. And I had occasion to sit through one of these classes recently, and I sat there thinking, why are they telling people this now? And they should have been telling them back before, you know, before the embryo was fertilized and implanted, right? It's been typically about a month, I think, of fetal development before you come in for one of these classes. And so I would urge anybody who's considering having a child to try and get into the class before the woman gets pregnant. It's useful. And sort of a related question to that, we were having a conversation here on the break about alcohol, drinking alcohol when you're pregnant. And there was some discussion about how much alcohol is dangerous. Like if you have a glass of wine with dinner at night when you're pregnant, is that a threat? I think this class said it was, that you should cut out all alcohol altogether. And I just wonder what current thinking is on that.
Well, I think most people would say, I mean, the safest thing is just not to drink when you're pregnant. I mean, it's hard to do really good studies of alcohol consumption. You know, a lot of it is recall and how much they were, remember that they drank when they were pregnant, and then looking at the effects on the children. So, it's really hard, and every person is going to be different too. I mean, someone who's bigger is going to have a lower alcohol level than someone who's smaller. So I think in general the safest thing is not to drink at all. I think if someone has a glass of wine a couple times in their pregnancy, it's not going to do anything. But, I don't think there's anyone who's going to say, it's fine to drink while you're pregnant.
Yeah, I mean, I think in terms of fetal alcohol syndrome, which is what you're concerned about, which is associated with anomalies and developmental problems, we don't know what the least amount is that is safe. And so we say to avoid it altogether. I don't tell my infertile patients to quit drinking altogether because they may not get pregnant for 12 months down the road, and we're in California, they may enjoy a glass of wine, and the best information we have certainly suggests that less than 5 alcoholic beverages a week don't either delay time to fertility or increase miscarriage rate. So I think if somebody has an occasional glass of wine, I'm not so worried about that. And if that's something that brings them pleasure in this stressful time course, it's fine. But once they get pregnant, I think the best information we have is that you shouldn't have any.
Along the lines of staying relaxed and stress-free when you're trying to become pregnant, could you say something about how infertility drugs, if they do influence cortisol levels at all? Do they?
I'm not sure that cortisol levels have ever been measured. It's one of the things we were going to look at with salivary cortisol in our acupuncture study to see if acupuncture led to more sort of de-stress type of thing, and using cortisol as an objective marker of stress. It's not a great marker of stress, quite frankly, and that's part of the problems that have tried to look at the impact of stress and fertility is we don't really have a great marker of stress. I'm not aware of any studies that have looked at hard objective markers like, say, cortisol levels with fertility drugs. I think different fertility drugs will have a different impact. The oral agents, which we think of as less potent or less strong, because the primary ones we utilize are anti-estrogens, and so they lower your brain's, they either lower the level of estrogen or they lower the way your brain sees estrogen. And most women, spot brains, expect to have estrogen, that women can have hot flashes, they can have moodiness, irritability. Interestingly, the, quote, more potent drugs, the actual FSH hormones, because it's the exact same hormone that your body makes, but in a higher dose, women interestingly tend to be have less side effects from those drugs than they do the, quote, weaker oral drugs. In terms of stress, a lot of that is kind of what you bring to the process. So for instance, an egg donor who's not infertile can be on the same drugs and not have symptoms, and the patient who's been infertile for 4 years and has gone through a bunch of treatments and she finally gets to IVF and she knows IVF is kind of the end of the road and she's on the same drugs, may be very stressed during that process, but it's a little hard to know whether it's the drugs causing the stress or the whole process. But I'm not aware of any objective marker like cortisol measurements when people have been on the medications.
My thought would be that, you know, if someone wasn't stressed out and they were just using the fertility drugs, you're using high doses of FSH, and that's essentially, you know, like having high doses in menopause. And I don't think menopausal women have higher cortisol levels than.
But they have lower estrogen levels, so it's a totally different hormonal environment.
But yeah, I don't think FSH itself should have a direct effect on cortisol.
Yeah, menopausal cortisol levels are unchanged.
Yeah.
Thank you.
So what advice would you have to a woman at age 42 who would like to have her own biological children?
Start right now. I mean, and I would, if someone, you know, was 42, I would probably think about seeing someone, you know, even sooner. Maybe just having a conversation with their gynecologist, you know, as soon as they're ready to start trying, just to make sure there aren't things that they could have overlooked or that could be an issue, because time is going to be the biggest problem.
But how do you rate the chances? I mean, it's presumably going to end in a scenario where you have to try IVF cycle after cycle to get lucky, basically, because the chances are probably relatively low, or?
Well, a 42-year-old doesn't, I mean, there are 42-year-olds who get pregnant, obviously, without doing any treatment at all. But we know that the chance per month is going to be relatively low. So, you know, to have a reasonable chance, they need to try over multiple cycles. And so they may want to start fertility treatment. That doesn't necessarily mean doing something like IVF, but perhaps doing something to increase the number of eggs that they're ovulating and perhaps boost their fertility a little bit that way.
It's just about 9 o'clock, so we have time for one more question. Yeah, Liz, the one.
I can honestly tell you that I'm probably, I am 48 years old. I have a 9.5-year-old son. When I was in my 20s, I did fertility drugs, sperm counts, everything in order to get pregnant. Nothing happened. I married another man, never receive this amazing gift. So now, just so you all know, no matter what happens, don't give up hope, because one way or another, if you want to get it, you can either, I mean, if you don't give birth biologically, there are a million children out there who need loving parents, and so there's no reason that you should go without having a child unless you want.
Thank you, Liz. Well, we've hit 9 o'clock, and I want to give these two just a big round of applause for having this conversation tonight. I just want to thank you from the bottom of my heart. I know open access to fertility is not something that happens on a regular basis, certainly not in a bar. And I really deeply appreciate you guys coming on and talking about a topic that can often be hard for us to talk about. And that is just so personal and at the same time seminal to who we are as people. So another big round of applause for Dr. Cedars and Dr. Westphal. Just a quick couple notes before we wrap up. Visit the website, sciencecafesf.com. Lots of articles. All the stuff from today will be on their video. If you haven't already, sign up for the mailing list up front and drop in a topic or a suggestion. We'll be back here. We'll be back here next month, third Tuesday of the month. The topic will be our drinking water. How does it get from the top of the mouth into our mouths, and what are the dangers of it? And really impending war over water rights in California. So I look forward to seeing you all next month. Thank you.
Quick, I gotta get tested.